Good morning. We're just about to get started. So hello and welcome to the ENVISION webinar on Safe Drugs and Safe MDA programs, Managing Adverse Events and SAEs for Neglected Tropical Diseases. My name is Kaylee Robinson. I'm a Capacity Strengthening Specialist for the ENVISION project at RTI International, and I'll be facilitating this third webinar in the ENVISION webinar series on NTDs. Today we're very happy to have Dr. Kumaraswami, Dr. Joseph Kamgno, and Dr. Abdel Direny as our speakers. We hope you find the presentations useful in your work to control and eliminate NTDs. For those of you who are new to webinars, some operational guidance is provided in the top right corner of your screen. You should be receiving your audio through your computer. If it's not working, you can connect through a landline with the phone number provided here if you click on telephone. And there's an access code that'll be provided if you click on that. If you do have any difficulties, please type your problem into the chat box or the question box and we'll try and help you resolve it. If at any time during this webinar you have questions for any of our presenters, please feel free to type them into the question box and we'll do our best to address these in the time that we have. The slides and a recording of this webinar will be available on the ENVISION website and you'll receive a link to them in an email following the webinar today. We'd also like to ask you to take a couple of minutes to complete a short evaluation at the end of the webinar, and we'll provide a link to this on the final slide. Your feedback is very important to us so that we can make sure we're addressing the topics that are useful to you and your daily work. And finally, if you find this webinar beneficial, you can find our previous webinars on our website, including one on assessing MDA coverage and another on completing the WHO Joint Application Package for NTDs. So very quickly, let me give a brief overview of the ENVISION project. ENVISION is a 5-year project funded by the U.S. Agency for International Development, or USAID. We work in partnership with national neglected tropical disease control programs for the control and elimination of lymphatic filariasis, onchocerciasis, schistosomiasis, 3 soil-transmitted helminths, and trachoma. ENVISION is implemented by RTI International, in partnership with CBM International, the Carter Center, Fred Hollows Foundation, Helen Keller International, IMA World Health, Light for the World, Sight Savers, and World Vision. ENVISION is implemented by RTI International and partners with 14 countries, including Latin America and the Caribbean, Africa, and Asia, and we'll be adding 4 more countries in 2015. And here's our website, and you can follow us on Twitter at RTI Fights NTDs. So let me introduce our speakers, who we're very grateful to have with us today. First, we have Dr. Kumaraswami, who's formerly with the Indian Council of Medical Research and is now a consultant for NTD programs with the NTD Support Center and ENVISION since 2011. He's a clinical researcher with over 3 decades experience with various aspects of lymphatic filariasis. We're also lucky to have Dr. Abdel Direny, who's an NTD technical advisor for ENVISION. He's a recent fellow at Emory University's School of Public Health and previously worked at IMA World Health, where he was the country director for the Haiti NTD program. He helped the national program there reach 100% scale up and begin the transition from MDA to measuring impact and starting surveillance. We also have Dr. Joseph Kamgno, who joins us from Cameroon, where he is senior lecturer at the Faculty of Medicine and Biomedical Sciences at the University of Yaounde. He's the director of the Center for Research on Filariasis and Other Tropical Diseases, and the Loiasis Technical Advisor at the National Onchocerciasis Task Force. So having such experienced speakers with us, we have a very interesting webinar prepared for you today. First, Dr. VK will provide an overview of the key steps in preparing for and managing serious adverse events and adverse events following MDA and national preventive chemotherapy NTD programs. And we'll then pause for a few minutes for your questions for Dr. Kumaraswami. After that, Dr. Direny will speak about Haiti's experience successfully managing adverse events to maintain effective coverage rates. And then Dr. Kamgno will speak about the situation in Cameroon and Central African Republic based on over a decade of his experience managing SAEs in areas co-endemic with onchocerciasis and loiasis. We'll then take time to answer more of your questions and get your feedback before closing the webinar. So I'd just like to remind you that though we do have these specific times prepared for our speakers to answer your questions, please go ahead and type them into the question box anytime they arise during the webinar. And with that, let's go ahead and get started. I'm going to pass the webinar over to Dr. Kumaraswami now. Just give me 1 second. All right, Dr. Kumaraswami, go ahead.
Thank you, Katie, for the introduction. In my presentation, I'm going to talk about an important aspect of MDAs that's not commonly addressed and which has the attention of program managers once these events that about occur. I'm going to talk about adverse events and serious adverse events and how we can be managing them more effectively. So we know that we are dealing with extraordinarily safe drugs in some of the largest public health programs that are currently operating to control or eliminate NTDs. These programs are unique because they treat several million people at the same time all over the world. And they are also unique because they're supported by large donations. The safety of the drugs that we use in these NTD programs has been established in several randomized controlled clinical trials, and the use over the last decade or more has certified their safety even in the field. However, because many people are treated over a short period of time, and because these drugs which are normally used in clinical practice are used outside the normal healthcare settings, there have been safety concerns now and then. So why do we need to pay attention to these adverse events and SAEs during distribution of drugs? Although several billion doses of these drugs have been given, we know that we need to be prepared to handle these occurrences and anticipate more of them occurring in the future simply because more people are going to be treated. As programs expand, especially in Africa, to include more people in areas which are previously not attended to, and also when more drugs are added to integrated approaches. We also know that these events, when they occur, SAEs or AEs, when they occur in numbers, can impact their PCT programs. We know of incidents in countries where the programs are ground to a halt because of the occurrence of AEs and SAEs. And once these events have stopped the programs, program managers have had enormous difficulties in restarting the programs and gaining back the community's support. How do these events occur and why do we see their impact? It's an important question that we need to answer. Most times they occur because we fail to anticipate that they may occur. At other times, it is the consequence of poor IEC and social mobilization, which could be very easily improved. But we all agree that it's important to effectively manage AEs and SAEs to ensure safe programs and also build the confidence of communities and ensure compliance in all rounds of MDAs. So before we get into the actual discussion, let me just define the events that we are talking about. The first is adverse event on MDA. Many of you who are familiar with the immunization programs will recognize that this terminology has been borrowed from the immunization program where they talk about adverse events following immunization. So we have simply grafted MDA onto the same acronym. These are events that commonly occur in programs, and most program managers know that they occur with frequencies that are usually related to the parasite loads in the community, and they are believed to be caused by the drug. That is the problem, because many people who receive the drugs, as well as people who administer the drugs, think that the drugs are actually responsible for the events that occur. But luckily for us, and from the experience that we know that most of them are self-limiting and can be treated with simple remedies. On the other hand, we talk of another set of events known as serious adverse events, which have many other implications, especially in terms of reporting to regulatory authorities. These are serious in the sense that they may result in death or require prolonged hospitalization, may result in significant disability, or may be life-threatening. In order to help program managers anticipate, plan, and manage these events, ENVISION, with USAID support and with other partners such as the Task Force for Global Health, and in consultation with health professionals from both public health and clinical sides, have developed a handbook whose availability is indicated in the webinar's handouts, helps program managers to manage these events effectively. If you have gone through this book, you will recognize that it is largely derived from the WHO guidance manual, which talks about how to manage adverse events and SAEs. The manual also has benefited from the large amount of experience that immunization programs of the WHO have gathered over the years, and these include the training manuals, the messages that need to be given to communities. All of them have been condensed in a useful manner so that a step-by-step approach is available for program managers to plan and manage AEs and SAEs effectively. The next slide actually tells you how the layout of the book is designed. It is designed in a manner that allows a program manager to approach the response to adverse events, both AEs and SAEs, in a step-by-step fashion. The most important aspect, as we shall see, is how do you respond to patient needs. Even as you respond to patient needs, we need to respond to community needs, including how do we communicate with the communities as well as the media. The next step is to determine if a particular event is an AE or an SAE, and how it can be investigated and reported, and what are the channels that are available for these activities. And finally, at the end of the investigation, after identifying the problem, what are the corrective measures that need to be taken? These may include several improvements to training or social mobilization, or even improving the quality of the drugs that are used in the program. And an important aspect of this exercise is the sharing of these experiences, because other people in the programs all over the world will certainly benefit from these experiences. The most important step, like for other areas of MDAs, is preparing for these safe distribution of the drugs. For this, the most important step is planning. And just as we plan for the distribution of the drugs in a very meticulous manner, we calculate the number of distributors that are required, the points from where the distribution will occur, and how coverages will be ensured and monitored. We also need to pay attention to how we ensure the safety of these drugs. And this will depend a lot on making up a calendar that allows you to train people to not only safely manage these patients, but also their responsibilities regarding reporting. Even as you plan for the MDAs, you need to inform the communities about what reactions can be expected following the use of the drugs. Because nothing is more frightening for an entire community to experience even the mildest of the reactions, not being told what will happen. Another effective measure of handling these reactions is the preparation and placement of rapid response teams. In many countries, during the course of the MDA, special teams consisting of physicians and nurses who have been trained to respond to these events are put in place, and it will be helpful if the communities are told where they are available and how they can be reached. Such rapid response teams can effectively bring down any rumor mongering in the communities regarding these SAEs and AEs. It is important to emphasize that the most critical step in the management of SAEs and AEs is the prompt treatment of patients. Even as patients experience these AEs and SAEs, they would like to know where to go for their treatment and how it will be treated. As part of the training to the health workers, if they are taught to recognize the most common ones, which most of us are familiar with, such as fever, headache, abdominal pain, or dizziness or giddiness, these are usually transient and can be treated with simple measures at the homes of the patients or at the primary health centers. Although these are transient and easily treatable, they can cause concern in the communities, as I have known in some situations where entire villages had a number of people who had been previously normal the days before the MDA and were suddenly laid down with fever, headache, and body pain. But all of them could be effectively treated in their homes. And an important message that one needs to reinforce while treating patients with these adverse events is to certainly emphasize the safety of the drugs over and over again. Another important message is to emphasize that it's not due to the drugs that they have these problems, but it is because of a good thing happening to them that the parasites are being killed, and it's a sure sign that the medicine is actually working. These two messages certainly reinforce their confidence in the drugs that they're taking and will help them to participate in future rounds of MDA. Another aspect of the training that needs to be emphasized is to recognize when a patient or an individual who is participating in MDA needs to be referred to a hospital or a specialist care once an event escalates in its severity. If any of these events progress or persist beyond 24 hours, or an unusual reaction which has not been previously seen has been observed, or an SAE has been observed, then the patient needs to be referred to the hospital. Even as we treat the individual patients, we need to keep in mind that the entire community needs attention. So whenever these events occur, it may be better that the program manager and his team reinforce the community understanding of the basic need for MDA, the safety of the drugs, and also address the media about the issues that they're facing. If an investigation for an SAE is undertaken, the community needs to be taken into confidence and also apprised of the various steps that are being taken. And if an investigation is conclusive, share the results with the media. The handbook provides a lot of guidance about how to handle the communities, what are the messages that need to be emphasized, and also provides guidance about how to handle the media, including holding a media conference and a press release. At this point, it is important to differentiate between AEs and SAEs. Adverse events, as we have seen, are common, expected, they are transient, and can easily be managed with common medications. On the other hand, serious adverse events, SAEs, are less common. Most often, they have serious consequences such as hospitalization, death, or disability. But the most important feature that the program manager needs to know is that AEs, although they occur in abundance, usually have no reporting requirements except maybe what is dictated by the national program. Whereas when SAEs occur, they need to be reported to the regulatory authorities, through a chain which usually extends from the national program to the World Health Organization. And it's shared by other stakeholders, such as those who donated the drugs and other funders of programs. So, although AEs may be severe in intensity, they rarely progress to serious events. And I will further examine this issue in the next slide. So, a common problem that we encounter when we discuss adverse events and serious adverse events is that there is some confusion between the usage of these terms, severity and seriousness. Many of us tend to use them interchangeably, but I should point out that they're not interchangeable. And although many severe reactions include serious reactions, it also includes other reactions that are not serious, as you can see from this diagram, which shows you the relationship between serious reactions and severe reactions. So the important aspect here is that serious reactions, as we talk about them in this context, have a regulatory context. So it's also the seriousness, not the severity, determines regulatory reporting obligations. To give you a very simple explanation of that is one could have a very severe headache, but it would not be a serious adverse event. The key message here is that all SAEs, when they occur, require action. And the handbook outlines what is the type of action that the program managers need to take into consideration. The most important issue is what should be reported. Although I said most AEs may not be required to be reported, many national programs may dictate what type of reactions need to be sent up the chain to the highest level. In many AEs, such as severe reactions, for example, Stevens-Johnson syndrome one encounters, or the Mazzotti reaction, these need to get reported, even though they do not meet the regulatory definition of AEs, when those events occur. When they occur with increased frequency, even when they're not severe, or they cause serious community concern, they may need to be reported. On the other hand, all SAEs need to be reported. And as I mentioned, the chain of command extends, or the chain of reporting will extend differently at certain situations. The question then comes, who should report? Virtually anyone who's involved in the program has an important role in identifying and reporting. Most often, this is done by the health staff, who should be properly trained to identify and report. This may include also volunteers and people who are close to the patient or the individual who will develop these reactions. And in some situations where there are researchers, all of them may be required to report these reactions. In reporting this, it is important that people who are expected to report are properly trained. Most often the burden falls on the primary care health workers. And over the years, we have recognized that several barriers exist that prevent effective reporting. This may range from guilt to lack of training in recognizing these reactions and reporting them. So program managers need to ensure that just as individuals are asked to be careful in counting the pills and dispensing them, that they also are properly trained to recognize and report these reactions. At the primary health center, training should involve the handling of commonly occurring AEs and certainly of all SAEs. And at the apex of the pyramid that handles all these cases, in the tertiary care hospitals and medical college institutions, it is important that there are a set of experts who can handle the most unexpected of these cases and routinely manage those that occur frequently. So how is this reported? This is reported using the WHO adverse event report form, which is extracted from the preventive chemotherapy manual, but usually adapted by many countries or agencies so that these are reported properly to WHO and other regulatory agencies. If these SAEs occur, they need to be investigated, and it is important to determine who will investigate and how this investigation will be conducted. The aim of this investigation is usually to identify what caused the problem. And once the problem has been identified, how the corrective action can be taken. So after conducting the investigation, one may come to any one of the following conclusions. That it was definitely related to the drugs. Many times these are identified as operational errors when individuals are forced to swallow the drug or experience a choking effect. Other times it is definitely not related to the drugs and may be due to a coincidence, which is more commonly seen in many situations after the AE or SAE investigation has been concluded. It may be related to the administration process, as I mentioned, where most often incorrect doses or incorrect administration is the cause of this issue. However, we must also remember that an investigation could be inconclusive and no definitive relationship with the drug can be drawn. If operational errors are identified during the program, then they need to be corrected. And luckily for us, most of them can be corrected by improving the training of the health workers and improving social mobilization, building in messages that will strengthen the participation of the communities. An important aspect is to allow these reactions that have been recorded and investigated to be linked with pharmacovigilance programs. A key element in all of this is avoiding a crisis, and if it does occur, how to manage that crisis. Here are some of the important points that will help in crisis management. If these are anticipated and trained personnel are available, then one needs to confirm the facts before making any of the statements and prepare a plan in case a crisis actually occurs. So the key to all of this is successful planning. We know we have safe drugs, so we need to ensure that there are safe programs. And the best way to do that would be to plan. And there is no better way to plan than use a checklist. The handbook provides a checklist that allows you to plan safe drug distributions and also carry out all these exercises that I've talked about so far. I'll stop there and see if you have any questions that I can take. Thank you for your attention.
Thank you, Dr. Kumaraswamy. It's a great overview presentation. We really appreciate it. Let's, as he said, pause for a minute to ask some questions. If you do have any questions, please go ahead and chat them into the chat box or the question box. And I'm going to, with that, pass the webinar over to Dr. Direny, who will share Haiti's experience, and then we'll go ahead and answer those questions towards the end of the webinar. So Dr. Direny, please go ahead, and we can see your screen. You have the display settings switched around.
Can you see the screen?
Yes.
Good morning, everybody. My name is Abdel Direny, NTD Technical Advisor at TI. I'm gonna quickly, in the next 5 minutes, talk about the AEs experience and adverse events. You can see that I don't say the word severe because any severe adverse event has been reported since the LF program has been started in 2008. The LF program has been started in one commune, Leoga. It has a baseline data of 50% of antigenemia. For the first MDA carried out in this commune, we had reported that a coverage of 85%. During this first MDA, a lot of adverse event was also reported, much more than what we have expected. And we didn't have enough medication to take care of the patient. The most common adverse events that we reported are shown in the left part of the slide, which are fever, headache, vomiting, diarrhea, abdominal pain, itching, testicular nodule. No death have been reported. In 2002, when we had the second round of MDA, the coverage was dramatically reduced to 52%. That created panic in the team, and we did a knowledge attitude practice survey to identify the reasons for this low coverage. And the survey revealed that 75% of non-participation was fear of side effects. And to increase the coverage, we were focused on education. We developed a flip chart with a real picture of people having side effects after taking the drugs, having voice of well-known people as political, religious authorities, soccer and music superstars, explaining the reasons of side effects. And we used these voices in radio and TV spots. We also increased the number of treatment points and medication. We increased the number of reference centers from 1 to 3. And as a result, the coverage was back up to 80% in the third round of MDA. And since there, consistent high coverage was reported during the rest of the program, and the number of adverse events have reduced every year. When the program expanded throughout the country in 2007 with the USAID funding, education on adverse events was included from the very beginning of the program. Community leaders informed the population about adverse events, why adverse events can occur, what they should do if adverse events occur, what the program has in place in terms of medication, health personnel to take care of them free of charge. As a result, a consistent high coverage was always reported for the entity program. And a knowledge attitude and practice survey conducted last year to determine the reasons for non-compliance in some areas. The result shows that the reasons for non-compliance were not side effects, neither safety of drugs, but the most common reasons were not present in MDA, which represented 15% of the responses. In conclusion, we can say that the management of adverse events or severe adverse events has an important impact on the NDD program. If you manage well the adverse event, the impact will be positive. You will have high coverage. If not, don't be surprised for a low coverage if you do not manage well the SAE. By educating, sensitizing the population on adverse events, you reduce a reason for non-compliance. Another lesson we have learned in the Haiti experience of SAEs is that you have to take into account all side effects, even if it's not related to the mass drug administration. Thank you, and I share with you this beautiful picture that we did during the 1 billion event in Haiti last year.
Great. Thank you very much, Dr. Direny. For those of you on the line, if you have any questions for Dr. Direny, please go ahead and type those in the question box as well, and we'll answer them after our presentation by Dr. Kamgno. I'm going to move right into that presentation so that we can stick with time. Dr. Kamgno, just give me 1 second. Okay, Dr. Kamgno, can you hear me? Are you on there? Dr. Kamgno?
Yes, I'm on, yes.
Great, we can hear you. Go ahead.
Yes, can you hear me?
We can hear you, and we have the slides already, so please go ahead. Thank you.
Okay, but I cannot see myself, the screen with my presentation.
Can you see the screen?
I see the screen, but it's the SAFE and SAFE drug and SAFE MDA program managing adverse event. It's not my presentation.
Okay, let me double check. Let's see. Apologize for this. Dr. Direny or Dr. Kumaraswami, can you see Dr. Kamgno's presentation on your screen?
Yeah, I can see it on mine.
Okay.
I can see it on mine also.
Okay, great. So, Dr. Kamgno, the screen is up, and all the,
I don't understand.
I'm sorry, all the presenters can see your screen. Or can see the presentation.
They can see me.
Yes.
They can or they can?
Yes, they can. So you can go ahead.
But I personally I do not see. But I will start with my PowerPoint here because I cannot see the
Okay.
presentation on your own screen. But I will use my own presentation, my own PowerPoint.
Great. We're right now on that first slide that says outline, and you can go ahead, or the plan slide. Go ahead.
Okay. So the few following minutes I will present the SAEs in Cameroon. There's a challenge of adverse event in onchocerciasis, low-risk co-anemic areas, the experience of Cameroon. So I will start with the history of SAEs in low anemic areas in Central Africa. It's not the Central African Republic, it's Central Africa in general. The strategy for MDA in low endemic areas, the current notification system, and the prevention of these post-ivermectin SAEs. So, concerning the SAEs in lower endemic areas in Central Africa, the treatments with ivermectin started in Cameroon in 1987. That's the third slides. I hope you are on the third slides.
Yes, we are.
So the treatment started in 1987, but the in onco-only areas. The adverse events that occurred were minor and moderate. Encephalopathies cases occurred when treatment started in forest areas, and the first case was described in 1991 in the Littoral region in Cameroon. And this case was analyzed and reported to WHO to Mexican donation program. Slides.
Okay.
From this first case, researches were conducted to determine the risk factors, the pathophysiology, the management, and the way of preventing these low-related severe adverse event. Slides. So, concerning the risk factors determined from research, the main risk factor was the heavy parasitemia of Filariasis. So the SAEs without neurological signs, the threshold was 8,000 microfilaria of lower per ml of blood, and the threshold for the probable Filariasis encephalopathy related to the treatment with ivermectin, the threshold was 30,000 microfilaria per milliliter of blood. So patients with pre-treatment parasitemia of 30,000 mf per ml or above, when they take ivermectin, they have a risk of developing encephalopathy after the treatment. Slide. Concerning the pathophysiology, the possibility are the mechanical phenomenon due to the paralysis of the numerous microfilaria and the blockage of the capillaries. So in normal subject, lower microfilaria, they migrate, they move in the blood system, but when patients take the treatment, these microfilaria are paralyzed and then drained by the blood through the capillaries, and there is blockage of the capillaries with dead microfilaria. The other mechanism is the immunological response to destroyed microfilaria. When microfilaria are alive, they are protected from the immune system. But when they are paralyzed or dead, they are now exposed to immunological system. So there is immunological responses due to destroyed microfilaria. And also there is a possibility of migration of the lower microfilaria to the brain, because in some cases recorded, when we did lumbar puncture, there was microfilaria in the cerebrospinal fluid. And in animal model, microfilaria have been seen in the brain tissue. Slides. And concerning the management of these particular SAEs, strategy was put in place for MDA in Filariasis endemic areas. And also there was a management protocol for these SAEs for cases in the health facilities. So concerning the strategy for MDA in Filariasis endemic areas, the first step after these cases were described was the mapping of Filariasis to delineate the risk areas. So after this mapping, we could then identify high-risk areas. And these high-risk areas, there was a setup of surveillance system for rapid detection and early management of cases, the training of health personnel before MDA for the diagnosis and management of post-ivermectin SAEs, and the enhance of community awareness and education with regards to these SAEs following treatment with ivermectin, so that in communities, people are well aware that after treatment they can have SAEs, because when they don't know that an SAEs can occur after treatment, when they suffer from SAEs, they go to traditional healer. They don't make the relation between the signs and symptoms they are having and the treatment they are taking. Because we have seen some patients after some days with traditional healers, they didn't make the relation with the treatment. So we educate populations about the possibility of these SAEs. And then there is drug preparation at the reference hospital for proper management of SAEs. So when we determine health structures that can manage SAEs, drugs are put in these, proper drugs are put in these health facilities for the management of these SAEs. And also there is surveillance by the CDDs and health personnel during the week after MDA for detection of eventual SAEs. And concerning the risk areas, the definition of risk areas for lower encephalopathy, after mapping, the risk area are those who have 20% lower prevalences with parasitological survey, or 40% prevalence of history of eyeworm passage. That is RAP-LOA technique for the mapping of LOA. And you can see on the 10 slides the map of Central Africa with the prevalence of LOA. And you can see on that map that the highest prevalence are recorded in the south of Cameroon, Equatorial Guinea, Gabon, Congo, Central African Republic, and Democratic Republic of Congo. Those are areas where you have high prevalence of LOA, and it is in these areas that people have risk of developing this encephalopathy when they take ivermectin. Slides. And concerning the statistics of this for this neurological SAEs or probable lower encephalopathy related to treatment with ivermectin, after the first treatment in high risk areas, we can record 2 to 3 cases per 10,000 treatment in these lower co-endemic areas after the first treatment. But we investigated in the Bakongo province in DRC, and the incidence was quite high. They recorded 5 cases per 10,000 treatment, because the prevalence of LOA was particularly high in this region of Bakongo in Democratic Republic of Congo. But with years of treatment, this incidence decreased, and in Cameroon, for example, this last year we record about 1 case per million treatment, because as the risk is related to the high MF in the blood, with years of treatment, we have less and less people with very high microfilariae of LOA in the blood, so the risk is quite low in communities after many years of treatment. And concerning the clinical presentation, the majority of these SAEs, they start 2 to 24 hours after the treatment. So the signs and symptoms start from 12 to 24 hours. And they start with minor and moderate adverse events. The main complaints are asthenia, severe lumbar pain, severe headache, and generalized arthralgia. Still clinical presentation, other signs observed are conjunctival hemorrhage, this red eye, so we see hemorrhage under the conjunctiva. This is not conjunctivitis, it is real hemorrhage under the conjunctiva. And we have noticed also retinal hemorrhage in these patients. In neurological cases, the main complaint is fatigue, that will increase progressively to behavioral disorder, trouble of consciousness, and even coma. And we have incoherent language in these patients, so they start talking about things that does not exist. They talk about things that they see but that does not really exist. Patient would complain about people around them for no reason. One of the patients had left his bed and urinated on his neighbor in the hospital hall. So the warning sign when we do the surveillance of these SAEs, it's pronounced fatigue, severe lumbar pain, severe generalized pain and hemorrhage of the conjunctiva. So when, after the treatment, patients who have these particular signs are closely followed because they can develop these encephalopathies. How about the management of these cases? As you can see on the 16th slides, when you have a warning sign in a patient after treatment, we do two basic exams: the calibrated blood smear looking for Plasmodium and lower. When lower is positive on the left side, we consider as a post-treatment adverse event, and it is managed as probable lower encephalopathy related to treatment with ivermectin. And also the hierarchy of the health system is informed. We start with the regional delegation of health, the NGOs that help the Ministry of Health in distributing the drugs, and also at the central level is informed. The National Coordinator of Onchocerciasis Control Program is informed, and we are informed because we work at the Center for Research on Filariasis and other tropical diseases, and we also manage these adverse events. So when there is a case, the hierarchy of the health system is informed, we are informed, and when there are signs that it is really an SAE, we go to the field and try to examine the patient with local health colleagues to confirm whether or not it's an encephalopathy related to the treatment with ivermectin. But when there is no lower and Plasmodium is positive on the right side, we treat the colleagues in the field treat as a malaria case. And the main concern for this lower encephalopathy, it is coma, because patients can develop coma, and when they develop coma, you can imagine how it can be difficult to manage a case of coma and the level of the district. And the management of the majority of these cases has been done at the district level, because during the first years of treatment, when cases occur, they were all brought to Yaounde, the central level. So there were so many cases at the central hospital in Yaounde that the management was very difficult. So the management was decentralized at the district level. So as I said before the launching of MDA, colleagues at the level of the district hospital are well trained about the management of these SAEs. So, for all unconscious patients, the important things are airway, breathing, and circulation. We also put urinary catheter or urinary condom. There is general nursing as classical resuscitation for this patient with trouble of unconsciousness, and there is also ocular care with saline. As you can see on the 18th slide, this it is a severe bed sore that we have with a patient after several weeks in the hospital, and for the prevention of these bed sores, we mobilize the patient to avoid these bed sores. You can see on the 19th slide the notification system. So when there is a case at the reference health unit, the form is filled, the declaration form as you see in the first presentation, and then this form is sent to the health district, and then from the district service, this form is sent to the central level so that we can send the form to MDP for these SAEs. And we also keep some forms at the national level for the statistics at the national level. Another form is sent to the National Pharmacological System at the Ministry of Health. And at the end of each treatment campaign, statistics of all the cases are sent back to the health system so that they are aware of the total number of cases each year. And the report is also sent at APOC and to WHO. And concerning the prevention of these SAEs, many strategies were tried because, as I said, the main risk factor is the heavy parasitemia of lower loa. So we thought if we could have a safe pre-treatment for loasis, we could give this pre-treatment drug to heavily infected patients to decrease, to get their parasitemia below the risk level before the ivermectin treatment. So we tried some clinical trials with low dose of ivermectin, with albendazole, with mebendazole, with anti-malarial drugs, but none of these drugs were really efficient to decrease progressively the parasitemia of lower loa. We have also developed with colleagues from French Institute de Recherche pour le Développement, NIH, Michigan State University, we have developed the test and treat strategy that consists of testing people for lower loa to determine those who are heavily infected and exclude them from mass treatment, to treat only those who are not at risk of developing SAEs after the treatment. So that's what I said. I had to say about the Cameroon experience. Thank you.
Great. Thank you so much, Dr. Kamgno. We really appreciate you having you here with us today. If anyone has any questions from Dr. Kamgno, please go ahead and type those in as well. We do have a couple minutes for a couple questions that have already been typed in. I'm going to ask one for Dr. Direny. One person has asked, what messages and channels were the most effective in improving Haiti's MDA participation rate?
Yeah, thanks for the question. I think the most effective channel that we can say is the media. I'm referring to radio and TV. We need also to consider the community meetings, education in the schools and the churches. And in terms of message, I can say that your message must be clear. It concerns the safety of the drug. Need to emphasize on that the prevention is the key for these diseases, and also inform the population about the adverse event.
Okay, great. Thank you very much, Dr. Direny. One other question we had is a general question for any of the presenters. If anyone's had any experience coupling with food donation programs, such as WFP, to reduce general AEs, especially those that might be related to praziquantel distribution. I wonder if anyone of the presenters would like to share. Let me make sure everyone's unmuted.
For Haiti, we don't really have experience with the food distribution, but it is something that we need to consider in this country, because for now we register that a lot of people that when they come to the distribution board, they are asking for more. But we don't really have experience with that, but it is something. If we can link with this the WFP program to do that, that would be great.
Thanks, Dr. Direny. Dr. Kumaraswami or Dr. Kamgno, any experience with that? And if not, we can also follow up with these questions by email to all the participants as well.
I don't have any experience with this.
Okay. We'll follow up by email. And I see that there's some other...
No, I don't have.
Okay, thanks. I see that there's some other questions that have come in as well. And unfortunately, we're at the end of our time today, but we will follow up with answers to some of those key questions. I just want to thank you all again for joining us. We really appreciate your time today. And a big thanks to Dr. Kumaraswami, Dr. Kamgno, and Dr. Direny for all your work in preparing your presentations and for sharing your expertise with us. I want to remind everyone that the slides and a recording of the webinar will be available on the ENVISION website, which is here. And then also in the side panel of your screen, the SAE handbook itself is available in English, French, and Portuguese. And if you're unable to get it from there, the ENVISION website also has all those documents available for you. So that's really the end of our webinar. If you could please fill out the survey, there's a link to it right here, and I'll copy it into the chat box as well. If you can just take a minute and give us some feedback on your experience, we'd really appreciate it. And with that, we'll close the session, and thank you so much for your time.
Thank you.
Thank you.
Thanks.